infections. Yeah, it doesn't going to cause any major infection at that point of junction itself because it is going to be asymptomatic, it is going to be silent for a longer period of time, and moreover, it causes lethal damage as the day progresses. So, if the patient is going to develop COVID-19 in this scenario, if the patient is harboring viral hepatitis B, if the patient is harboring viral hepatitis C for a long-standing time, or if the patient is being diagnosed with a new episode of COVID-19 scenario right now, how are you going to approach these kind of patients is the most important thing that I would like to discuss right now along with you all. See, if you're today the learning object is my area of interest to disclose with you all today about something about the basics of viral hepatitis B as well as C, and also about SARS-CoV-2 virus. And see, if you're going to think about that severe acute respiratory syndrome COVID-2 virus, which is right now pandemic throughout the world and is threatening the entire world, and almost around 2 to 6% of case fatality rate has been reported pandemically throughout the world. See, if you want to discuss about this scenario and how COVID-19 is going to affect your liver, and we are all having some sort of questions. See, are we having, suppose if the patient is having diagnosed to have hepatitis B, also if the patient is having diagnosed to have hepatitis C like infections, and if you are having any positivity for this kind of infections, or your increased risk for acquiring COVID-19 is still a questionable issue, and should suppose if your patient is being diagnosed with B and C, and if you have been diagnosed with COVID-19, how are you going to be, how to treat this kind of scenarios, and how can you protect yourself if the patient is having B or C and from acquiring COVID like life-threatening infections. And if you're going to look into the data, see, if you all know, see why I have taken this topic to discuss, because as we all know that the World Hepatitis Day being celebrated in the month of July in 28, almost, if you're going to look into the data, almost if you're for major health-related illness like HIV, tuberculosis, malaria, see, these are all various illnesses that we are well known, and various protocols and guidelines, everything has been well established. But so far, even multiple trials are going on for COVID and other scenario, and we have been treating with multiple line of newer regimens, but even then, there is no one significant vaccine has been not yet derived, even in this pandemic. That's the main entity. And if the patient is having, see, as we all know that the COVID and respiratory SARS-CoV-2 is predominantly going to involve the AT2 alveolar type 2 cells in the lungs, and also it can affect your GI tract. If it is going to affect your GI tract, if it is going to affect your hepatocytes, how does it is going to progress, how the manifestation is going to be, that's the main area for me to discuss with you all right now. So, for example, if you want to take about hepatitis B and hepatitis C, in India, almost 40 million people has been diagnosed with hepatitis B. Also, approximately 6 to 12 million people been diagnosed with hepatitis C. So, if you are going to take this scenario, regarding first we will discuss about hepatitis B. So, 40% possibility for this, suppose if the patient is having evidence of chronic liver disease, there is high possibility for this patient around 30 to 40% of the cases can progress to hepatocellular carcinoma, and around 20 to 30% of the patients can progress to cirrhosis if the patient has been acquired chronic hepatitis B viruses. For example, if the patient is being acquiring chronic hepatitis C virus, so there is around 12 to 30% of the population can go for hepatocellular carcinoma, and around 20 to 30% of the population can go for cirrhosis. See, why I'm discussing all those entities, because as we all know, the case fatality will be approximately 2 to 6% in COVID-related cases, and if the patient is being harboring with this kind of infection, if the patient is presenting with any liver injury or any acute hepatitis or any evidence of chronic hepatitis, how are you going to manage in the background of COVID-19? That is one of the most important entity. And so far throughout the world, almost around 1.34 million deaths has been reported because of hepatitis, and 325 million people worldwide has been reported with the evidence of chronic hepatitis B or C viruses so far has been proved. So, as we all know the basic things, this is mainly by horizontal, also by vertical mode of transmission, and acquired by either, see, if you're mother to child, it will be going around 30 to 40% of the patients can be vertical mode of transmission, and remaining by any is either by sexual contact, as sharing razors or syringes, or tattooing. There are multiple practices which is going to be there for you to have hepatitis B virus, and always you need to take. And one thing we are not supposed to forget that regarding the user of, regarding needle prick injury. Suppose if the patient is going to present with any needle prick injury of evidence of any hepatitis B related patients, so how are you going to approach? But that area is not me much of interest to discuss right now, because our entity to discuss more about COVID, so we are skipping out those areas. But always you should remember, so these are all the major modes of transmission and blood-borne contacts and blood transfusion, so many other things. So if you're going to look into the scenario, HBsAg, you're going to look into the, so how many percentage of patients are being HBsAg positive? Almost around 1 to 12% of the population throughout being proved that HBsAg positive is being there globally, has been reported, and anti-HCV almost around 0.09 to, around 4 to 5% of the population anti-HCV positivity is still being reported globally. And if you're going to look into this hepatitis C, which is most threatening virus, because it doesn't going to show any symptoms in the initial phase, and if you're only thing, if you're going to see hepatitis B will always go for a chronicity more, because, and also hepatitis C will also show chronicity, but hepatitis B you need to treat for lifelong, and hepatitis C there is a constrained duration of time, depends upon your clinical presentation. Either you can treat the condition for 12 weeks, or you can intensify the regimen, or if the patient is having underlying cirrhosis in the background of hepatitis C, we can take over the condition for almost 24 weeks to be treated. So if the patient is going to be having evidence of hepatitis C, because there is high possibility for this kind of patients to progress to hepatocellular carcinoma, and it's always a growing problem, and nowadays more cases have been reported, and 3.5 million people, that's what have been discussed, been living with hepatitis C virus, and there is high possibility around 4 to 5% of the population can progress to hepatocellular carcinoma, and at least 20 deaths being occurring every year with this kind of presentation like hepatitis C virus. It's always a silent epidemic that we should not forget, and it always carries a huge burden, because if you are going to have hepatitis C virus for a longer duration, one thing to diagnose is anti-HCV and HCV RNA quantitative analysis. If you are going to diagnose a condition, and if you are going to treat, it's well and good. Suppose if you're not going to diagnose, if you're going to harbor, there are multiple complications, chronic liver disease and other complications, and like cirrhosis and hepatocellular carcinoma will set in as the day progresses. So if you want to discuss about the COVID-related virus, it can be either because of COV, which is, that's the COV1, which is initially happened in the phase of 2000 to 2000, the 2002 to 2003 period. And at that point of time also, around 50 to 60% of the patients showed evidence. There are some case reports have been sure that around 50 to 60% who presented to us with GI symptoms like nausea, vomiting, and diarrhea. And even now, there are high possibility for the patients to present with the GI symptom for even SARS-CoV-2, severe acute respiratory syndrome, and even Middle East, MERS. So if you're going to look into MERS, means it's Middle East respiratory syndrome. So in this condition, it's predominantly involved in Middle East countries, and the pathway for this condition to affect the liver is entirely different from the pathway for SARS-CoV-2 to affect the liver. For discussing about the pathophysiology, how SARS-CoV-2 is going to involve your liver, that I'll be coming in my upcoming slides. And see, as we all know, it's a single-stranded RNA virus like hepatitis C. It's the main pathway to enter is mainly because of angiotensin converting enzyme, ACE receptors. See, as we all know that all the receptors will be abundantly present in the lungs. Also, it can be present in the intestinal tract, even in your hepatocytes. It can be present in your cholangiocytes. If you're going to look, so cholangiocytes is nothing but bile duct. So if you're going to see how the ACE receptors is going to express, nothing but it will going to involve the smooth muscle cells. It can also involve hepatocytes as well as cholangiocytes. But the ratio of involvement of cholangiocytes is almost 70 to 80% more than, around 20 to 30 times more, and 70 to 80% of the population, more involvement of cholangiocytes will be there rather than involvement of the hepatocytes. But even then, cholangiocytes be involved high. The possibility of alkaline phosphatase, GGT, which are the favorable liver markers for the cholangiocytes, have not been very significantly elevated during the phase of SARS-CoV-2 infection. But AST and ALT ratios, and AST and ALT, everything will be significantly elevated. Around 40 to 50% of the SARS-CoV-2 patients have been shown evidence of COVID-2 related patients will be shown evidence of elevation of the AST, ALT related liver enzymes. So what is going to happen? See, this is the outline of structures, what have been discussed. As we all know that SARS-CoV-2 structures mainly based upon single structure RNA with the envelope and spike glycoprotein, which is going to be attached to the filaments. And apart from that, see, if you're looking into the uh, coming to the pathophysiology of the SARS-related virus, how does it going to affect your liver? That is the main area for me to discuss now. See, if you're going to take the SARS-related virus, multiple pathway is being involved to cause damage to the liver. Suppose, for example, it can mediate damage by direct damage by cytotoxic effect. Also, it can produce damage by antibody-dependent enhancement. And sometimes what will happen, once a virus is going to enter, it can predispose to cells and cytokine storm. As we all know, that very frequent complication, day in and day out, daily we're reporting all these things. And also, it can predispose to ischemic injury, and also it can predispose to any reperfusion hypoxemic injury. See, first, if at all, if you're going to take about the direct damage, so if you're going to look into this, so direct damage, once because of the virus, if it's going to affect the liver, so direct damage, how does it going to predispose? It will be predisposing to zone 3 involvement. Zone 3 sinusoidal dilatation and patchy necrosis and lymphocytic infiltration and hepatocyte necrosis. Multiple things is going to be affected, and by T cell mediated damage, but also by macrophage stimulation. All these things is going to be involved. So the SARS, you all well remember, the SARS contains S protein. That S protein, it's going to act on ACE2 cells, and it will be having affinity in bile duct around 20 times more than the hepatocytes. So what is going to happen? It will predispose to multiple injuries, immune injury, SARS, cytokine storm, as I discussed with you. And based upon that, the various injury is going to set in. This is by one mechanism. And next to that, antibody-dependent enhancement. So what do you mean by this antibody-dependent enhancement? As you well know, if you're, for example, if you're going to take dengue, the clinical scenario that initially before COVID era, we reported our practice more with dengue-related complications, dengue hepatitis, and multiple cases have been reported. So, for example, if you're going to take dengue, the first, genotype doesn't going to cause much of harm, followed by if the patient is going to infect with the second genotype or some other strains, what is going to happen? There's nothing but antibody-dependent enhancement process which is going to set in. That will predispose to multiple complications and cytokine storm, inflammatory response, and complement depletion, other things which will predispose to shock and other pathology. Like that, the same scenario is exhibited here also. The antibody-dependent enhancement, what is going to happen? So virus antibody will going to get attached to your FCR receptors, and also it's going to relate to attached to the complement receptors. So what is going to happen? So the virus is going to enter into the granulocytes, monocytes, and it starts replicating inside, and it predisposed to increased production of virus, which will predispose to multiple complications. This is by antibody-dependent enhancement. And suppose if you're going to look into the pathway of SARS, as we all know, the septicemic process, very interesting area to discuss, because as we all know that SARS, sepsis, severe sepsis, MOD, shock, this is the most common, followed by death. So this is the most common scenario in right from day one of MBBS. We are going to read this scenario for the management for the septicemic protocol to identify. So if the patient is going to present with systemic inflammatory response syndrome, what is called as SARS, and once cytokine storm is going to set in. So what do you mean by the cytokine storm? The tumor necrosis factor activation, interleukin pathway activation, and endotoxin production by the own organism. So all these things will be predisposing to multiple cytokine pathway activation, will predispose. See, the level of some interleukins will be raising. For example, the level of 1, 2, 6, 10. The multiple interleukins is going to raise, and which will predispose to inflammation, and it will predispose to multi-organ dysfunction, and it will predispose to liver injury, myocardial injury, or renal injury. There are multiple complications can be reported. And once, see, this SARS and cytokine storm is usually, if the patients, as you all know, the COVID-related virus can occur at any point of time. Usually, around acute presentation, it can present up around day 2, and it can last up to around day 14 also. But most of the complications will be in the initial phase, around day 2 to day 7 will be the most of the complications is going to happen. As we all know that that is a crucial period, but the incubation key period can be prolonged even up to 12, the maximum long incubation period that has been proven is up to 12.5 days has been reported in the various case studies. So based upon SARS, based upon direct damage, and based upon antibody-dependent enhancement, and one more part is nothing but ischemia and reperfusion injury. So what is going to happen in ischemic? Suppose if once the lipids is going to get accumulated, once the glycogen is going to get depleted, once the glycogen is going to get consumed, and once the lipids going to get accumulated, followed by once the ATP is going to get depleted. So what is going to happen? There will be obviously anaerobic glycolysis going to be going to set in, followed by lipid accumulation, hepatocyte signal transduction. Everything is going to get affected, followed by which will predispose to the cell death. Hepatocyte death is going to set in. So this is a pathway what I want to discuss. So if the patient is going to present with SARS COPD as an acute presentation in this, based upon this pathophysiology, it is going to affect your liver. It can predispose to acute hepatitis or some other complications also, but this kind of presentation, the case reports are slightly been low when compared to the respiratory events. So, as I discussed with you, it can also predispose to ischemic and reperfusion injury. And moreover, there is one more entity of toxicity by COVID-related virus to your hepatocytes by a drug-induced liver injury. Suppose if you are going to treat with multiple conditions, some patients will be treated with chemotherapeutic regimen, some patient will be treating with anti-tuberculosis drug, some patient may be initiated with antibiotics and so many other chemotherapy and some other antivirals. And suppose if the patient's post-transplant, other scenario, you are going to treat with some other. See, for example, this diagram has shown if a patient being treated with, for example, the patient being treated with ritonavir for a post-transplant other conditions, and in this patient, what is going to happen? The CYP3A4 pathway, it is going to get activated. Once the CYP3A4 pathway gets activated, it is going to predispose to liver injury mainly by ROS formation. Reactive oxygen species is going to get formed, the free radical mediated injury, the apoptotic mediated cell death is going to set in, and mitochondrial dysfunction, calcium influx, abnormal excretion, and plenty of discharge, and all those things is going to happen, and multiple pathways like caspase activation and endoplasmic reticulum activation, inflammatory response, all these things. This is the main pathway for me to discuss about how the SARS-CoV-2 will affect your liver, and based upon mainly by once a mitochondrial dysfunction is going to set in, there is high possibility of chromatin marginalization, nuclear condensation, cytoplasmic vacuolization. As what we are remembering, basic pathology, this is the thing which is going to happen for the apoptotic pathway and caspase activation, which will predispose to hepatocyte dysfunction, also to the cell death. So this is about the basic outline pathophysiology. So our intention to prevent this complication, we need to intervene the patient at earlier point of time. Most of the even doing the patient with during COVID-19 to prevent the damage of prevent the damage of acute viral hepatitis to set in. And next to that, suppose coming to the scenario of hepatitis B as well as C. So suppose if you are having hepatitis B or C, are you at increased risk of COVID-19? This is more frequent question. See, hepatitis B or C virus is definitely going to be a chronic virus, and if you are going to get in this kind of setting, if the patient has already been diagnosed, if the patient has already been in follow with the hepatologist, and if the patient is going to diagnose with this condition, always you need to have thinking in this kind of pandemic, are you at increased risk of getting COVID-19 or not? Are you at increased risk of developing severe COVID-19? So what is a severe COVID-19? As we are well know, there are multiple definitions for that. See, if the respiratory rate is high, and if the, along with the evidence of dyspnea, mild dyspnea, which means mild. If the rate is going to be high, along with the patient is going for severe dyspnea, and moreover, if the patient is having lung infiltrates, around 50% of the lung is going to get involved, it's nothing but moderate stage. And what do you mean by critical? Once this kind of phases, the cytokine storm is going to set in, multi-organ dysfunction, and septicemia. Kindly mute down, please. So if all these things is going to set in means, so that will predispose to critical. So if you see, if the patient is having severe, which means critical COVID-19 scenario, the possibility of your liver injury will be very high, and possibility of complications with B and C will also be high. there is a significant graph which has been shown in multiple various studies, but I didn't quote all those things because of lack of time. But you should remember there are multiple risk factors for patients with chronicity of hepatitis B and C to acquire COVID-19 that I'll be showing with you all in my upcoming slides. So, are people with hepatitis B or C at increased risk of getting COVID-19? This is a question that what you have been getting frequently in your mind, but there are multiple studies as per the AACD position statement, some multiple studies, AACD statement, what I mentioned, some experts suggest no. But if the patient is getting severe COVID, as I discussed with you, there is possibility of still high chances still there. Are people with hepatitis B or C at increased risk of developing severe COVID-19? So, how advanced your liver disease? As we all know that your liver disease, based upon the chronic liver disease, if it is going to exist for a period of around 6 months, even it could be because of multiple sources. It could be because of alcohol, or it could be because of metabolic, or it could be because of viral. So there are multiple etiology for you to set in a liver disease. But once a liver disease, how advanced is liver disease? Based upon your MELD, that's nothing but model of end-stage liver disease scoring, and based upon the modifications of MELD, like MELD sodium, also based upon the childbirth status. See, all these things has to be, whether the patient is falling in childbirth A or B or C, all these things has to be taken into account. How advanced your liver disease is, and based upon that, will be categorized, or you're at higher risk of population to exhibit severe COVID-19 infection in the background of hepatitis B or C. So this is a slide what have been taken from AACD position statement, which has been reported recently, and see, most of the studies what's happening right now are mainly based upon what's happening in Wuhan and in China. Based upon studies will be done, had been done mainly based upon China and other reports, because our country databases have not been still been validated, because see, in India the GI symptoms are not more common when compared to other parts of the world. And if you're going to look into that, see, this is AACD statement has been taken mainly from the epicenter, which has been established in the month of January in China. So the common presentation will be, as we all know, that any respiratory ailments like upper respiratory, lower respiratory, fever, fatigability, dry cough, anorexia, malaise, so many things are going to be there. And if you're going to look into the complications like common GI presentation, nausea, vomiting, diarrhea, as we are well know, will be around 10 to 20% of the cases being reported, but some centers have shown evidence of around 30 to 40% of the cases also been reported. As I have discussed with you, the Chinese control for disease control and prevention, what have been reported based upon this clinical presentation, whether the patient falls in mild pneumonia or moderate or severe, or with evidence of septic shock or multi-organ dysfunction, all these things to be taken into account for categorize a patient with evidence of COVID-19 are at risk of hepatitis B or C is the most important criteria to be taken into account. So we need to assess a clinical presentation. We need to see the clinical symptom, in which symptom the patient is presenting with evidence of COVID-19. So if you're going to look into this slide, who are at risk for severe COVID-19? Suppose if the patient is asthmatic, if the patient is immunosuppressive, if the patient is diabetic, if the patient is hypertensive. As we all know that hypertension is one of the most common complications and age related. Suppose as the age goes high, if it is going more than 65 years, there is high possibility for you to develop more complication because of COVID, and also it can predispose to chronic liver disease. Always you should remember, and see if the patient is having diabetes and any hemoglobin disorders or immunocompromised, if the patient is going for organ transplant, steroid medication for a longer duration of time, and if the patient is morbidly obese. See, these kind of things can always, these kind of patients, as per the CDC position statement, what they mentioned, and these kind of patients will be having severe risk for developing COVID-related pathology. And so this is what I've been discussing in the previous slide. So commonest cause, if you're going to look into the high precipitating factor, the high comorbid, the high possibility for morbidity is mainly because of the triggering factor of hypertension, which is almost taken in around 20 to 20% of the cases, and diabetes next to that will almost take around 10 to 12% of the patients. And apart from that, GI presentation in the background of COVID is always slightly lower because around 1 to 2% of the cases only been reported with GI, and the severity to establish a severity. Only in case of severe COVID-19 infection, there is high possibility. Around 40 to 50% of the patients can go for elevated levels of AST, ALT enzymes. But in the initial phase, there is not high possibility for the patients to go for elevated levels. And moreover, if you're going to look into the pediatric data, the very less of case reports have been there to to evaluate. To say there is elevation of AST and ALT liver enzymes in the background of COVID-related pathology. So as we all know that what we all well know, as per the various statements, AASLD, ACG guidelines, as per EA's statement has been according to EA's position statement, what we all well know about this COVID-related virus, also about hepatitis B and C, and see what they've been telling on 14 to 15%, see there will be predominant of AST, ALT ratios will be elevated as I discussed with you, and bilirubin will be slightly less, total bilirubin elevation will be slightly less than AST, ALT. So usually if it is going to be more than 2 times the upper limit of normal, as we have taken the cutoff, it should be around less than 30 to 40, and if the patient is going to have more than 2 times of the upper limit of normal, there is high possibility. But severe COVID-related injury, that it can go even up to 4 to 5 times of the upper limit of normal. But always you should remember the enzymes like AST, ALT, and ALP, also GGT can be taken into account, but ALP elevation will always be less, and GGT elevation, there are few centers in Wuhan and China been reported, GGT elevation also been significantly reported in patient with COVID-19 and other infections. So if you're going to see what are the various predisposing factors, as we all well know, very important predictors of injury is albumin level. So if the patient is going to have very low serum albumin, so as we are going to take the cutoff of around 3.5, it is going to come down around 1.5 to 2.5 of the albumin. So if you are going to take that kind of cutoff, the patient is going to present that so the clinical presentation will be having, most of the time the patient will be in state of volume overload status, that will predispose to myocardial dysfunction, that will predispose to ARDS, that will worsen the complication of COVID, which will make the patient for ventilatory failure, which will predispose to respiratory arrest, and which will predispose to cardiovascular dysfunction, and finally the patient is going to succumb because of this kind of presentation. So low serum albumin, which is a very strong predictor, also the significant elevation of AST, ALT with GGT and ALP can also be taken into account, and bilirubin levels will be mildly elevated, but no more elevation of case reports is still not more common because of isolated COVID and other pathology. And if you're going to look into the histology, it can predispose, if the patient is going to have SARS and other, a COVID-related virus, it can predispose to microvascular steatosis, and it can predispose to macrovesicular steatosis, it can predispose to hepatocyte ballooning, necrosis, lobular infiltration, bile duct infiltration, cholangiocyte proliferation. So many things are there to discuss about the histopathology. So what we don't know, that's the most important thing we should remember that. See, suppose if the patient is having elevated liver function in COVID-19, whether it is mainly because of the viral effect, or it is secondary to inflammatory, or it is secondary to immune response, or it is secondary to a drug hepatotoxicity. We are not very sure what is the reason for this trigger to set in. That has to be, and the more case reports are still needed to validate this kind of presentation. And next to that, are patients with chronic liver disease, for example, B as well as C, are in the background of fatty liver. Always you should remember that fatty liver, morbid obese, type 2 diabetes, hypertension, the background of thyroid, they're all more susceptible to severe liver injury from SARS-CoV-2. So whether the patients are patients with chronic liver disease more susceptible to liver injury from SARS-CoV-2, but the papers are not been much of documentation still more needed, because it can be a multitude of various complications, but isolated presentation with this kind of events has still needed more papers to quad this kind of events, presentations. And next to that does SARS-CoV-2 exacerbate cholestasis in patients with PBC, that means primary biliary cholangitis or primary sclerosing cholangitis. If the patient is having the cholestatic liver conditions, if the patient is going to present with cholestatic pathology, which could be of multiple causes, and whether this COVID-related pathology which is going to exacerbate the cholestasis, which means it's still not been, no much of papers have been reported. So these things, we don't know the exact events, what's happening right now. So once if you're going to diagnose a patient with hepatitis B, you're very sure, you're very sure, very sure that you're going to put the patient on antiviral support, and you're going to start for a lifelong therapy with sequential viral markers, as well as DNA monitoring, as well as screening the patient for a progression of chronic liver disease, as well as screening the patient for progression of hepatitis carcinoma. All these things you're going to do along with consecutive management. And suppose if the patient is asymptomatic, even if the patient is having B and C, and even if the patient is having COVID-19, but if the patient is having asymptomatic presentation, even then we need to monitor consecutively whether the patient is having any other progressive complications is there or not. So lab parameters, and see what are the patient concerns. One is because of, during this lockdown it's very difficult because so much of things have been affected, but in India now the lockdown has still not been fully opened out, but even still minimal lockdown is still going on. Going to pharmacy, but during the initial phase, which was happened in the month of March, April, May, June, there are so much of issues at that point of time, whether to go to pharmacy or appointments or online consultation, and so many things have been happening to confuse me, which will make you confused. And I would like to state one simple thing: always a clinical presentation, clinical examination is the most important to diagnose a patient rather than online consultation before winding up. And next to that, virus testing. As you all know, COVID-related virus testing, so many modalities as there. RT-PCR has been well available, and serology, viral antibodies, so many things. That's a separate area to discuss in microbiology perspective. That's not going to take into account. So, if the patient is going to be having evidence of chronic liver disease, always you should kindly mute yourself, sir. So suppose if the patient is going to have evidence of chronic liver disease, always if the patient having evidence of compensated cirrhosis, or if the patient is going for decompensated cirrhosis, or if you're planning the patient for liver transplant, or you're going to do something else, for suppose if the patient is having hepatitis carcinoma, or in case of special situations, like suppose if the patient is having autoimmune liver disease, or if the patient is having NAFLD, NASH, or if the patient is having any other complications, coexisting alcohol, there are so much of other triggers out there. See, always you should remember that if the patient presents you with evidence of compensated cirrhosis, so always we need to specialized visit we can postpone, and routine lab testing can be performed in this kind of patients. Suppose if the patient is having viral hepatitis, and doesn't mean that if the patient is having viral hepatitis, they are not having much of increased risk even during the severe course of, no increased risk of severe course of COVID-19, even if the patient is having viral hepatitis. And consecutively follow-up is the most important. And NAFLD patients always, as what have been discussed, they will most of the time will be morbidly obese. Diabetic hypertension will be a coexisting pathology. All major comorbidities, all major risk factors will be presenting in NAFLD presentation. For this kind of patients, monitoring for SARS-CoV-2 is most important, because these kind of patients are a high possibility for respiratory failure, cardiac arrest, as well as death. And autoimmune pathology, why I'm going to discuss about this, because these kind of patients we are going to subject for a longer duration of steroids. And if the patient is going to be subjected for longer duration of steroids, there is high possibility for immune compromise to establish. Once a patient is going to develop immune compromised state, there is high possibility for the patient to acquire multiple infections like SARS-CoV-2 and other things. But if this patient is going to develop immune compromise, even the patients develop COVID-related pathology, we should not stop the dose of steroids. We need to continue steroids for a duration of time, and consequently we need to switch over the higher antibiotic support, and we need to manage, provided which doesn't going to affect your liver, whatever the drugs you are going to initiate. Because always you should remember that COVID-2 doesn't mean that if the patient is having COVID-2 and other pathology, always we need to look for other possible etiology also, even if the patient shows evidence of COVID-related positivity. And always you should remember that you need to exclude other possible common etiological factors, even if the patient is having COVID positivity. I don't think that if the patient is having COVID positivity, you should investigate only for that, and your management is only for that. Not like that. It is always a multiple presentation, multitude of involvement, and based upon one clinical scenario, we should not take it into account. Always we need to manage as a combined approach, the best possible treatment we need to give to the patient. And next to that, and very important thing, how to list the patient. See, even in many centers in Chennai, during this period of lockdown, the patient listing for transplant, and there is a huge waiting is being happening for transplant listing, because most of the centers being converted to COVID centers, because and even then the transplant criteria, the long waiting list being going on, there's a long haul in the journey, and if the patient is going to be in long waiting list, there are multiple complications. The patient can develop multiple complications, and the patient can go for, and the patient most of the time will die because of other complications. And since the patient's being this is the major issue even during this transplant. So nowadays, if the patient before transplant SARS-CoV-2 is made a dictum to check for the patient, whether the patient even for the donors as well as for the recipient, everyone we need to screen for the SARS-CoV-2. Testing is the most important thing to be considered in the management of liver transplantation protocol. And suppose if the patient is going to living donor transplant, and we can consider the patient by case series. And main thing, always we need to vaccinate the patient for streptococcus pneumonia and capsulated organisms and H influenza coverage. All these things to be taken care into an account. And if your patient is going to present with evidence of chronic liver disease, your routine management will not change. You need to manage the patient as per the dictum of chronic liver disease, as per the dictum of antivirals, as per what is happening for the patient with B or C. The routine management has to be continued. You should not stop the patient even if the patient develop COVID-19. And even if the patients, once a patient being developed severe respiratory, severe COVID, severe critical respiratory events, critical organ dysfunction, if it is going to set in, at that point of time, we need to alter the drugs. Apart from that, if the patient is having mild to moderate presentation, no need to alter the basic drugs, what's happening for the management of chronic liver disease. And so after once the patient be done with liver transplant, so after liver transplant, always you should remember that there are multiple immunosuppressive molecules you are going to use for these kind of patients. And if you are going to use multiple immunosuppressive molecules, that it's a high point for you to develop COVID-related complications. And make sure that you are going to vaccinate this kind of patients. And always you should remember that there are multiple case reports. For example, I'll be giving you a clinical scenario few months before in some centers, what they've been showing. Initially, they have done a liver transplant. Within a week span, the patient developed fever and other complications. The blood culture, they have taken the swab, which showed evidence of nasal swab, showed evidence of SARS-CoV-2. And we need to make sure that some certain drugs like mTOR inhibitors, some tacrolimus and other drugs. So these are the drugs which will frequently be used in the post-transplant management protocol, and we need to taper the dose of these kind of drugs. Always you should remember, when you're going to taper the dose of these kind of drugs, there is high possibility for the liver to go for rejection in the post-transplant period. So we should not completely stop. We need to taper the drug, and we need to assess clinical signs of improvement, and we need to see how the patient is going to respond to this line of treatment based upon the clinical presentation. So, and what is the problem for surveillance in the background of chronic liver disease in hepatocellular carcinoma? Always, if the patient is having chronic hepatitis B, or if the patient is having chronic hepatitis C, we need to have a frequent surveillance with the alpha fetoprotein as well as imaging, ultrasound, other imaging to be done in the interval of at least a 6 months period. But this kind of patients, if the patients, because of this COVID lockdown and other scenario, and this surveillance definitely had a strong impact, which has definitely came down, and most of the time the surveillance won't be done in a proper manner. So so much of issues being happened. Some patients develop hepatocellular carcinoma, worsening. This is a basic outline what they've been given about what are the various liver pathology, what are the various liver complications that can set in if the patient is going to harbor a COVID-19 and other pathology. So, and before starting the treatment, always you should remember whether you're going to initiate, should I continue my treatment for hepatitis B or C if you are going to acquire COVID-19 in the initial phase. And if you have been in B and C treatment, do not stop the treatment. Always look for flare, as well as in hepatitis C means you need to look for the resistance of the molecule. And suppose should I start treatment for hepatitis B or C in the background of, suppose if they newly diagnosed B and C in the background of COVID-19 means, so if you have already been on treatment, you continue the treatment. There are no strict contraindications to start antivirals for viral hepatitis due to COVID-19. So If the patient is having COVID-19, doesn't going to have much of symptoms, no need to stop anything. You can start the regimen for hepatitis B, also for hepatitis C management. So this is a basic outline what I've been taken from my ACD statement. So see, this is based upon chronic hepatitis B, also for the chronic hepatitis C. You remember this simple diagram. So if the patient is to be in chronic hepatitis B, if the patient is going to develop COVID-19, and if the patient is on treatment for chronic HPV, you continue, one thing. And if already untreated hepatitis B in the carrier trait, so you can definitely continue hepatitis B virus treatment. You can consider the treatment because to prevent flare in this kind of presentation. And if the patient doesn't have a COVID-19, means you can no harm in treating the patient. Definitely you can go for the treatment. If the patient is going to be having evidence of hepatitis C with COVID-19, if on treatment for hepatitis C, always you should remember the treatment for hepatitis C is for a lot shorter duration, around 3 months, some patients for 2 months, and some patients for 3, and we can go up to 6 months based upon, and always we need to monitor the serial HCV RNA levels to assess the response. And there are so many other predictors like fibrosis index, fibroscan, so many other things to be taken into an account with endoscopic surveillance also to look for evidence of varices and other complications, to look for evidence of cirrhosis and other complications, to look for evidence of chronicity for this kind of diseases to progress. And with imaging support to prevent to assess whether the patient is progressing to hepatocellular carcinoma. And if this kind of patients is going to develop COVID-19 on treatment, suppose if on treatment for HCV, you continue the treatment for HCV. No only direct acting antivirals is most important. We can continue. In the initial phase, what we use interferon, ribavirin, not much in use because ribavirin sometimes can be tried for some patients which will predispose to hemolysis. Case reports have been reported. And if the patient doesn't have evidence of COVID-19, so newly diagnosed means you can start the treatment. No worry about this COVID-19 pandemic. And always, if you are going to start the treatment, you need to assess the drug-induced complications based upon that. And always, if the patient is immunosuppressed and some other molecules, if you are going to use, and always you look for reactivation of hepatitis B. So, before concluding, I would like to say that if the patient on treatment for B or C, if you are going to harbor COVID-19, doesn't mean that the symptoms is mainly because of COVID-19. Always you need to look for alternative cause, you need to look for other possible etiology, you need to screen the patient, do a complete workup for fever and other profiles if it is going to set in, and don't take one thing into account to treat. So, hepatitis C virus treatment, there are multiple antivirals, direct acting antivirals as we are well known, and so much of regimens based upon various genotypes is being available, and mainly is based upon injection support, not mainly based upon pill-based regimen, not based upon injection-based regimen. And cure rates, if you're going to initiate at the earlier stage, almost around 95% of the most population with compositors will be having a reasonable cure rate. That's the most important thing to be discussed. And so in this lockdown, during this initial phase, COVID-19, which has been more common at that point of time during this lockdown, whether the hepatitis B and C medication has been supplied adequately, which means it's still a questionable issue, but now it has been, B and C medications have been reasonably available right now in India and even during this COVID pandemic. So no worry about B and C medication, which is available in most of the government centers and even available in most of the corporates and other things. So COVID-19, the shortage of medication is definitely not going to make a major impact right now because there's reasonable production of B and C medications even during this COVID pandemic, which is there right now. So how can people with hepatitis B can protect yourself? Always the protection is very simple. As we all know, the social distancing, at least we should give a gap of around 6 feet. And next to that, hand washing, frequent hand washing, that should be at least every time if you're going to wash your hands, it should be at least for 20 seconds. And if you're going to use disinfectant, it should be contains around alcohol, approximately around 60% of the alcohol. And you need to use face covers, masks, N95, so many things and so many webinars is being happening because of that. And it's not my major area of interest to discuss all those things. Always you should remember, if you want to save your liver at the right point of time to prevent this kind of complications, you need to take care of your hypertension, hypertension, you need to take care of your diabetes, you need to control your diet, lifestyle modification, exercising, regular aerobic exercise has to be done in a proper manner. And if you have any set of complications, if you are planning to initiate on any medications, never hesitate to consult a gastroenterologist regarding that. Always, before starting on any medications for this kind of presentation, you need to be in frequent surveillance with the gastroenterologist and nephrologist. It's the most important thing to be taken care of. And so healthy lifestyle, and if you're alcoholic, quit alcohol. If you're a smoker, quit smoker. If you're a drug abuser, quit that. All those things are supposed to be, if we develop, and so try to avoid expose yourself to more, major pollutants, and always maintain a social distancing, and try to consult if anything is possible, if it's possible through online or phone, if try to consult. But only thing I would like to tell, if you want to make a strong clinical diagnosis, you should not do only online consultation. The clinical presentation of the patient is the most important, and when you are doing a clinical examination, is the most important thing to be taken care, because a chronic liver disease doesn't mean that the patient is having ascites, hepatic NCAF, coagulopathy. All those things will be having multiple presentation. All those things will be predisposed to major complications. All those things the patient can develop so much of issues. So everything to be taken into account, taken care into account to manage this kind of presentation. So overcome this COVID-19 and save your liver, make India a hepatitis-free nation. And you all should remember that the theme for World Hepatitis Day 2020 is nothing but hepatitis-free future. And we need to make sure that we are going to make India a hepatitis-free future, and we need to make the world globally a hepatitis-free future. That has to be strongly established by following all these guidelines and make India a healthy nation. Thank you very much for patient listening, and I'm happy to take up your questions if there is anything to take over.
Recording is on.
Yes, sir.
Yes, sir.
So we have just a moment.
The questions you can take over my questions. Anything is there.
We have a couple of questions here. So,
Yes.
Whether the surveillance for chronic liver disease be affected during the lockdown?
I think I have discussed about this now. See, most of the time, the surveillance for chronic liver disease has definitely been affected during this lockdown, because if you all know that for hepatitis B, for hepatitis C virus patients, and moreover, they need to stand in a long gap. They couldn't able to maintain the social distancing, other possibilities. Everything will not be able to do in a proper manner. Next to that, the imaging investigations, the lab investigations during this lockdown period will not be happening in a proper manner. So the surveillance for evidence of chronic liver disease to progress to hepatocellular carcinoma definitely had an impact, definitely affected during this lockdown, and most of the patients, many patients been died because of this kind of complications. But right now, as many of the centers have been open, and we should be very well aware about the second peak of COVID-19, which is going to, they are telling the second peak is going to, sometimes it may set in. Always you should take care of all the major precautionary measures, whatever it is possible from our side.
Right, sir. Thank you, sir. Sir, and one more question, sir. So, whether cholestatic jaundice can happen in COVID-19 hepatitis?
Isolated cholestatic jaundice been reported in various AACD position statements. Very less of case reports been documented, but isolated cholestatic hepatitis very less of. Since even then the cholangiocytes has been involved around 20 times of more affinity than your hepatocytes, isolated cholestasis is definitely low. But ALP and GGT elevations have been documented in various literatures, but many of the literatures has been documented in China, not in our country.
Right, sir. Sir, and is there any poor prognostic marker to assess liver disease in COVID-19?
So, as I discussed with you, there are multiple poor prognostic markers. Also, you should remember that I have discussed with you all the major comorbidities like hypertensive age, if it is going to be more than 65, diabetic, hypertensive, thyroid, all those things can be added on to your prognostic marker. But the significant poor prognostic markers are your liver enzymes, your total bilirubin, and one strong important thing you should not forget that your albumin levels. If your albumin is going to be very low, there is high possibility for you to go for volume overloaded pathology. Volume overload pathology will predispose to multiple complications. So all these things can be taken as an account, but one single pointer means serum albumin will be taken as a strong pointer to assess your severity of liver disease during this pandemic of COVID-19.
Right, sir. Sir, is there any risk of outbreak of hepatitis A in COVID-19 pandemic?
Hepatitis A being frequently reported, but it's enterically transmitted, being frequently reported in multiple places. But even then, hepatitis A is going to be reported. It can predispose to only acute as well as sometimes to acute liver failure. But if the patient is going to set in with acute liver failure in the background of COVID-related pathology, sometimes the manifesto and the clinical presentation will be very high. But even then, always there, if you're well aware about that, there is very good vaccinations being available, live attenuated vaccines being available for hepatitis A. If you're going to take that vaccine, if you're going to screen yourself, so don't worry about that kind of complications.
Right, sir. Sir, and what is the role of immunosuppressants in patients who develop COVID-19 in post liver transplant scenario?
So role of immunosuppression in doing, that's what I've been discussed. Huh? So if the patient is having, if the patient in post liver transplant scenario, if the patient is going to develop COVID-19 because of your immunosuppressive regimen. So for example, I gave you for example tacrolimus, everolimus, multiple drugs are there. You need to slightly reduce the dose and we need to assess for response. Only if the patient is having severe respiratory failure, severe thing complications, then we need to stop the drug. But until then, we are not supposed to stop because these kind of drugs will prevent the rejection. So we need to continue the immunosuppressive based upon the your severity, and you should not. You can give it a slightly lower dose at around. You can maintain the tacrolimus level at around 10 milligrams, nanograms, and if you're going to do that, it will be very, fairly well enough rather than entirely stopping the molecule for post liver transplant patients to prevent rejection and other complications and graft
Right,
dysfunctions.
right, sir. Thank you, sir. So, what is the risk of liver disease in pediatric patients and who have exhibited COVID-19?
The risk of liver disease in pediatric patients, see, even for pediatric patients, the severe respiratory dysfunction or severe liver dysfunction, the case reports are very, very low, and there are not much of case reports have been there. And usually in pediatric patients, the AST elevations also been very low. The risk of liver disease has been very low, and not much of case reports been happened in pediatrics, and not much of studies, even in the NASPAGAN and SPAGAN criteria, not much of studies have been included. So very less of case reports been documented in pediatrics.
Right, sir. So, there's one more question, sir. If a patient is continuously taking hepatitis B or hepatitis C drug during this long pandemic, whether they need to go for any blood checkup and monitoring needed to be done?
Yes, obviously. It's a very simple question. If the patient is going to be on chronic hepatitis B as well as hepatitis C virus treatment, the patient needs to be on lifelong follow-up. Even then, if the patient is having chronic hepatitis C, once the patient been treated, so sometimes the patient deserves treatment, follow-up for at least at an interval of around 6 to 12 months with SCBR and imaging support to see whether the patients have any other complications. I have seen some patients, even after the full dose of hepatitis C virus treatment, there is some recurrence and some patients can develop multiple other complications also. Sometimes, even after the full dose of treatment, the patient can develop chronic liver disease. There are multiple case reports have been there, and always the patient has to be in surveillance to prevent the progression for long-standing cirrhosis as well as hepatocellular carcinoma. For B, no obvious doubt, definitely B-related pathology to be monitored lifelong. The serial follow-up of imaging, lab parameters, endoscopic surveillance for your varices to monitor the patient for evidence of chronicity in liver disease, and all these things to be taken into account for managing a patient with chronic hepatitis B. The surveillance is the most important parameter to be taken into account.
Right, so thank you so much, sir. That was a really enriching presentation. I'm sure it was literally helpful for all the participants. And I thank all the doctors who have spared time and had come and participated in our webinar. And I'd like to thank Dr.
Madam,
Arun and
I
all
have
the
one question.
doctors.
I have one question. I am Dr. Kannan.
Yes, sir.
Yes,
Yes,
sir.
Dr. Khan, please, please.
Can I have if you permit me?
Yes, sir. Yes, sir. Please proceed.
Yes, sir. Yes, sir.
Arun is an elegant and electrifying talk. Almost covered all the aspects of COVID-19 pathology and the perspective with the hepato diseases. So as you alluded rightly, that the most vulnerable population are the diabetes and obesity because they do have the increased this one exposure for the insulin resistance and hyperinsulinemia. Because both the compartments are have to belong to the this one category of NAFLD and NASH also. In this perspective, what is the role of micronutrients in preventing the COVID-19 pathology or any complication like vitamin, this one water soluble vitamins or fat soluble vitamins in enhancing the innate immunity? What is your perspective over that?
Sir, thank you, sir, for sharing your point of view. And if you are going to think about non-alcoholic fatty liver disease, it's an entirely different scenario. See, if the first presentation will be an isolated fatty liver. Once the patient being affected with fibrosis and other complications, steatosis will progress to a non-alcoholic, non-alcoholic steatohepatitis. Once the patient is being going to develop steatohepatitis, the patient can go for fibrosis, can go for cirrhosis, can go for hepatocellular carcinoma, and then finally is going to die. So this based upon on which presentation you are going to manage. That's the most important in the background of various comorbidities like what have been discussed like diabetes or hypertension. And next to that, if the patient presents to you with evidence of non-alcoholic fatty liver disease, definitely there is a strong evidence of the role of micronutrients. And also you can take care of vitamin E, which has been shown in multiple trials. For example, Prevent's trial has been shown that a high dose of vitamin E definitely is having a strong impact. And also the micronutrient supports, for example, zinc and other micronutrient, other supports, even if they are going to take for a longer duration, there is a strong impact. I mean, not even a very strong impact, but a reasonable impact in prevention of the progression of patients to chronic liver disease. But so going to supplement these micro nutrients based upon your diabetes to prevent the microvascular, also to prevent the macrovascular. Also, it will take care of your comorbid conditions like diabetes and hypertension. So, micronutrient supplements definitely is having a reasonable role, not only for the non-alcoholic fatty liver, also for the primary comorbid triggers which is going to happen. So, micronutrient can be supplemented.
Then Arun, the given treatment for COVID-19, especially is a remdesivir. You know about the remdesivir is an antiviral drug
Yes.
for COVID-19,
Yes.
and also the immunomodulating agent like IL-6. In case of
Yes, sir.
hepatitis B, it is because IL-6 immunomodulator.
Yes, sir.
So
Please tell me.
both the agents are hepatotoxic. In that scenario, what is your recommendation as an antiviral and an immunomodulator agent for the hepatitis B patients who are already having this one hepatic decompensation problem?
Sir, hepatitis B treatment is entirely different. Either we are going to use a patient with tenofovir or entecavir, that doesn't going to alter. But once you have been diagnosed with COVID-19, the strong established protocol in managing COVID-19 has not been established so far for your kind information. So there are multiple trials. If you are going to put the patient with remdesivir, there are very few, reasonable case reports around 10 to 13% of patients being presented with elevation of transient liver enzymes. But doesn't mean that the patient is having evidence of liver failure. So transient liver enzymes, once you step down the molecule, within a period of time, within a period of week, it's definitely going to improve your liver function. So transient and transaminitis is going to, it's going to set in, but doesn't mean that this is one of the most, always, that's what I'm telling you, the liver injury can predispose either because of drug induced, or it could be because of antibody dependent enhancement, or it could be direct damage, or it could be SIRS. And always we should not take one thing into an account. Say if the patient is being remdesivir, always we need to take multiple things into an account before stopping the drug remdesivir.
Thank you, sir. Very informative talk. Thank you very much. Thank you, sir. Thank you.
Thank you, sir. Thank you, Dr. Kannan, for your valuable response.
Evidence,
If there are no further questions, I think we can wind up the session.
Yes, sir. So I'd like to thank you from CIPLA We would like to thank you for this time that you have spared us, and it has been an enriching experience for all the participants, sir. So we would like to thank you and all the participants and wishing you a happy Sunday, sir. So thank you.
Thank you very much. Thank you all for patient listening and work on this pandemic. Thank you very much.